Welcome to This Week in Surgery, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Surgery has you covered. Our podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the surgical field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Surgery, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine, including in the operating room. This week in surgery, we will be discussing recently published articles. First, Annals of Surgery. Systematic review and meta-analysis of laparoscopic versus open radical nephrectomy for pediatric renal tumors with focus on Wilms' tumor. Objective: to summarize and evaluate the outcomes of laparoscopic radical nephrectomy, LRN, and compare its safety and efficacy with open radical nephrectomy, ORN, in pediatric renal tumors, RT, and Wilms' tumors, WAIT. Background: ORN is the gold standard treatment for pediatric RT, consisting predominantly of WAIT. LRN is gaining popularity but remains controversial in pediatric surgical oncology. Methods: a systematic search was performed for all eligible studies on LRN and comparative studies between LRN and ORN in pediatric RT and WAIT. Meta-analysis, subgroup analysis, and sensitivity analysis were conducted. The main endpoints were cancer-related outcomes and surgical morbidity. Preferred reporting items for systematic reviews and meta-analysis guidelines were followed. Results: no levels I to 2 studies were identified. LRN was feasible in nearly 1 in 5 pediatric RT and WAIT after neoadjuvant chemotherapy, with pooled midterm oncological outcomes, less than 7% local recurrence, greater than 90% event-free survival, comparable with those of ORN. There was no strong evidence of an increased risk of intraoperative tumor spillage, but lymph node harvest was inadequate in LRN. Large tumors crossing the ipsilateral spinal border were associated with a trend for intraoperative complications and positive margins. Pooled complications rate and hospital stay duration were similar between LRN and ORN. Long-term, greater than 3 years, outcomes are unknown. Conclusions: available Level 3 evidence indicates that LRN is a safe alternative to ORN for carefully selected cases, with similar spillage rates and midterm oncological outcomes. However, there was no advantage in surgical morbidity and lymph node harvest was inadequate with LRN. Tumor matched group studies with long-term follow-up are required. Regional social vulnerability is associated with geographic disparity in waitlist outcomes for patients with non-hepatocellular carcinoma model for end-stage liver disease exceptions in the United States. Objective: this study was undertaken to evaluate the role of regional social vulnerability in geographic disparity for patients listed for liver transplantation with non-hepatocellular carcinoma, HCC, model for end-stage liver disease, MELD, exceptions. Summary and background: prior work has demonstrated regional variability in the appropriateness of MELD exceptions for diagnoses other than HCC. Methods: adults listed at a single center for first-time liver-only transplantation without HCC after June 18, 2013 in the Scientific Registry of Transplant Recipients database as of March 2021 were examined. Candidates were mapped to hospital referral regions, HRRs. Adjusted likelihood of mortality and liver transplantation were modeled. Advantaged HRRs were defined as those where exception patients were more likely to be transplanted, yet no more likely to die in adjusted analysis. The Centers for Disease Control Social Vulnerability Index, SVI, was used as the measure for community health. Higher SVIs indicate poorer community health. Results: there were 49,494 candidates in the cohort, of whom 4,337, 8.8%, had MELD exceptions. Among continental US HRRs, 27.3%, and equals 78, were identified as advantaged. The mean SVI of advantaged HRRs was 0.42 versus 0.53 in non-advantaged HRRs, p equals 0.002, indicating better community health in these areas. Only 25.3% of advantaged HRRs were in spatial clusters of high SVI versus 40.7% of non-advantaged HRRs, whereas 44.6% of advantaged HRRs were in spatial clusters of low SVI versus 38.0% of non-advantaged HRRs, p equals 0.037. Conclusions. An advantage for non-HCC MELD exception patients is associated with lower social vulnerability on a population level. These findings suggest assigning similar waitlist priority to all non-HCC exception candidates without considering geographic differences in social determinants of health may actually exacerbate rather than ameliorate disparity. Minimum and optimal CA19-9 response after 2 months induction chemotherapy in patients with locally advanced pancreatic cancer, a nationwide multicenter study. Objective. This nationwide multicenter study aimed to define clinically relevant thresholds of relative serum CA19-9 response after 2 months of induction chemotherapy in patients with locally advanced pancreatic cancer, LAPC. Background. CA19-9 is seen as leading biomarker for response evaluation in patients with LIP, but early clinically useful cutoffs are lacking. Methods. All consecutive patients with LIP after 4 cycles, FOLFIRINOX or 2 cycles gemcitabine nab-paclitaxel induction chemotherapy, plus or minus radiotherapy, with CA19-9 greater than or equal to 5 U per milliliter at baseline were analyzed, 2015 to 2019. The association of CA19-9 response with median OS, MOS, was evaluated for different CA19-9 cutoff points. Minimum and optimal CA19-9 response were established via log rank test. Predictors for OS were analyzed using Cox regression analysis. Results. Overall, 212 patients were included, of whom 42, 19.8%, underwent resection. Minimum CA19-9 response demonstrating a clinically significant median OS difference, 12.7 versus 19.6 months, was seen at greater than or equal to 40% CA19-9 decrease. The optimal cutoff for CA19-9 response was greater than or equal to 60% decrease, 21.7 versus 14.0 mo, p equals 0.021. Only for patients with elevated CA19-9 levels at baseline, N equals 184, CA19-9 decrease greater than or equal to 60%, hazard ratio, HR equals 0.59, 95% C, 0.36 to 0.98, P equals 0.042, was independently associated with prolonged OS, as were SBRT, HR equals 0.42, 95% C, 0.25 to 0.70, P equals 0.001 and resection, HR equals 0.25, 95% C, 0.14 to 0.46, P less than 0.001, and duration of chemotherapy, HR equals 0.75, 95% C, 0.69 to 0.82, P less than 0.001. Conclusions. CA19-9 decrease of greater than or equal to 60% following induction chemotherapy as optimal response cutoff in patients with LIP is an independent predictor for OS when CA19-9 is increased at baseline. Furthermore, greater than or equal to 40% is the minimum cutoff demonstrating survival benefit. These cutoffs may be used when discussing treatment strategies during early response evaluation. Quality of life and gastrointestinal symptoms in long-term survivors of pancreatic cancer following pancreatoduodenectomy. Objective. To describe long-term quality of life, QOL, and gastrointestinal (GI) symptoms in patients who underwent pancreatoduodenectomy for pancreatic cancer in the modern era. Background. As advances in pancreatic cancer management improve outcomes, it is essential to assess long-term patient-reported outcomes after surgery. Methods. Patients who underwent curative intent pancreatoduodenectomy for pancreatic cancer between January 2011 and June 2019 from a single center were identified. Patients alive greater than or equal to 3 years after surgery were considered long-term survivors, LTS. LTS who were alive in June 2022 received a 55-question survey to assess their call, EWORK QLQC30, and GI symptoms, EWORK PAN 26 and problem areas in diabetes questionnaire. Responses were compared against population norms. Clinico-demographic characteristics in LTS versus non-LTS and survey completion were compared. Results: 672 patients underwent pancreatoduodenectomy for pancreatic cancer, 340 were LTS. 137 patients of the 238 eligible to complete the survey responded, response rate, 58%. Compared to the U.S. general population, LTS reported significantly higher call, 75 versus 64, p less than 0.001, less nausea/vomiting, pain, dyspnea, insomnia, appetite loss, and constipation, but more diarrhea, all p less than 0.001. Most patients, N equals 136-137, 99%, reported experiencing postoperative GI symptoms related to pancreatic insufficiency, N equals 71-135, 53%, reflux, N equals 61-135, 45%, and delayed gastric emptying, N equals 31-136, 23%. Most patients, N equals 113-136, 83%, reported that digestive symptoms overall had little to no impact on call, and 91%, N equals 124-136, would undergo surgery again. Conclusions: despite known long-term complications following pancreatoduodenectomy, cancer survivors appear to have excellent call. Specific long-term gastrointestinal symptoms data should be utilized for preoperative education and follow-up planning. Generating a prioritized list of operative procedures for simulation-based assessment of general surgery trainees through consensus. Objective: to develop appropriate content for high-stakes simulation-based assessments of operative competence in general surgery training through consensus. Background: valid methods of summative operative competence assessment are required by competency-based training programs in surgery. Method: an online Delphi consensus study was conducted. Procedures were derived from the competency expectations outlined by the Joint Committee on Surgical Training Curriculum 2021 and subsequent brainstorming. Procedures were rated according to their perceived importance, perceived procedural risk, how frequently they are performed, and simulation feasibility by a purposive sample of 30 surgical trainers and a 5-person steering group. A modified Copenhagen Academy for Medical Education and Simulation Needs Assessment formula was applied to the generated data to produce ranked procedural lists, which were returned to participants for reprioritization. Results: prioritized lists were generated for simulation-based operative competence assessments at 2 key stages of training: the end of Phase 2 prior to the development of a subspecialty interest, and the end of Phase 3, that is, end of training certification. A total of 21 and 16 procedures were deemed suitable for assessments at each of these stages, respectively. Conclusions: this study describes a national needs assessment approach to content generation for simulation-based assessments of operative competence in general surgery using Delphi consensus methodology. The prioritized procedural lists generated by this study can be used to further develop operative skill assessments for use in high-stakes scenarios, such as trainee progression, entrustment, and end-of-training certification, before subsequent validity testing. Next we will be discussing articles from Journal of Vascular Surgery. Hypertension during transfer is associated with poor outcomes in unstable patients with ruptured abdominal aortic aneurysm. Objective: limited data exists for optimal blood pressure, BP, management during transfer of patients with ruptured abdominal aortic aneurysm, RAA. This study evaluates the effects of hypertension and severe hypotension during interhospital transfers in a cohort of patients with RAA and hemorrhagic shock. Methods: we performed a retrospective, single-institution review of patients with RAA transferred via air ambulance to a quaternary referral center for repair, 2003 to 2019. Vitals were recorded every 5 minutes in transit. Hypertension was defined as a systolic BP of greater than or equal to 140 mHg. The primary cohort included patients with RAA with hemorrhagic shock, greater than or equal to 1 episode of a systolic BP of less than 90 mmHg, during transfer. The primary analysis compared those who experienced any hypertensive episode to those who did not. A secondary analysis evaluated those with either hypertension or severe hypotension less than 70 mm Hg. The primary outcome was 30-day mortality. Results. Detailed BP data were available for 271 patients, of which 125, 46.1%, had evidence of hemorrhagic shock. The mean age was 74.2 plus or minus 9.1 years, 93, 74.4%, were male, and the median total transport time from helicopter dispatch to arrival at the treatment facility was 65 minutes, interquartile range, 46 to 79 minutes. Among the cohort with shock, 26.4%, N equals 33, had at least one episode of hypertension. There were no significant differences in age, sex, comorbidities, AAA repair type, AAA anatomic location, fluid resuscitation volume, blood transfusion volume, or vasopressor administration between the hypertensive and non-hypertensive groups. Patients with hypertension more frequently received pre-hospital antihypertensives, 15% versus 2%, P equals 0.01, and pain medication, 64% versus 24%, P less than 0.001, and had longer transit times, 36.3 minutes versus 26.0 minutes, P equals 0.006. Episodes of hypertension were associated with significantly increased 30-day mortality on multivariable logistic regression, adjusted odds ratio, AOR, 4.71, 95% confidence interval, C, 1.54 to 14.39, P equals 0.007, 59.4%, N equals 19, versus 40.2%, N equals 37, P equals 0.01. Severe hypotension, 46%, N equals 57, was also associated with higher 30-day mortality, AOR, 2.82, 95% C, 1.27 to 6.28, P equals 0.01, 60%, N equals 34, versus 32%, N equals 22, P equals 0.01. Those with either hypertension or severe hypotension, 54%, N equals 66, also had an increased odds of mortality, AOR, 2.95, 95% C, 1.08 to 8.11, P equals 0.04, 58%, N equals 38, versus 31%, N equals 18, P less than 0.01. Hypertensive and severely hypotensive episodes during interhospital transfer were independently associated with increased 30-day mortality in patients with RA with shock. Hypertension should be avoided in these patients, but permissive hypotension approaches should also maintain systolic BPs above 70 mm Hg whenever possible. Exploring the impact of gut microbiota on abdominal aortic aneurysm risk through a bidirectional Mendelian randomization analysis. Objective: the abdominal aortic aneurysm, AAA, is associated with alterations in the composition of the gut microbiota. However, the precise causal relationship remains unclear. Elucidating this complex interplay could provide new insights into the pathogenesis of AAA. Methods: a bidirectional two-sample Mendelian randomization analysis was conducted using genome-wide association study summary data on the gut microbiota, N equals 18,340, and AAA, N equals 353,087. A total of 196 gut microbial taxa across taxonomic levels were examined for their potential causal effects on AAA risk. Conversely, the effect of AAA on these microbial taxa was also analyzed. Results: 9 microbial taxa were identified as having a causal influence on AAA risk. Specifically, increased risk were associated with genus Balaphila, odds ratio, or 1.359, P equals 0.0119, genus Cadenibacterium, or 1.348, P equals 0.0058, genus family 13AD3011 group, or 1.507, P equals 0.004, genus Oxalobacter, or 1.157, P equals 0.0449, and genus Prevotella 7, or 1.194, P equals 0.0306, whereas decreased risks were linked to class lentispheria or 0.829, p equals 0.0361, order Victivolales, or 0.829, p equals 0.0361, family Victiviaceae, or 0.814, p equals 0.0057, and genus Anerotrunchus, or 0.773, p equals 0.0497. Furthermore, AAA was found to influence the abundance of 14 microbial taxa across various taxonomic levels. Notably, bidirectional associations were observed with the class Lentisphaeria and the order Victivolales. Conclusions. This study provides novel evidence for a reciprocal causal relationship between gut microbiota and AAA risk, thereby offering new insights into the pathogenesis of AAA. These findings also suggest promising avenues for microbiome-based therapeutic interventions. Development and validation of a machine learning prediction model to improve abdominal aortic aneurysm screening. Objective. Despite recommendations by the United States Preventive Services Task Force and the Society for Vascular Surgery, adoption of screening for abdominal aortic aneurysms, AAAs, remains low. One challenge is the low prevalence of AAAs in the unscreened population, and therefore a low detection rate for AAA screenings. We sought to use machine learning to identify factors associated with the presence of AAAs and create a model to identify individuals at highest risk for AAAs, with the aim of increasing the detection rate of AAA screenings. Methods. A machine learning model was trained using longitudinal medical records containing lab results, medications, and other data from our institutional database. A retrospective cohort study was performed identifying current or past smoking in patients aged 65 to 75 years and stratifying the patients by sex and smoking status, as well as determining which patients had a confirmed diagnosis of AAA. The model was then adjusted to maximize fairness between sexes without significantly reducing precision and validated using six-fold cross-validation. Results. Validation of the algorithm on the single-center institutional data utilized 18,660 selected patients over 2 years and identified 314 AAAs. There were 41 factors identified in the medical record included in the machine learning algorithm, with several factors never having been previously identified to be associated with AAAs. With an estimated 100 screening ultrasounds completed monthly, detection of AAAs is increased with a lift of 200% using the algorithm as compared with screening based on guidelines. The increased detection of AAAs in the model selected individuals is statistically significant across all cutoff points. Conclusions. By utilizing a machine learning model, we created a novel algorithm to detect patients who are at high risk for AAAs. By selecting individuals at greatest risk for targeted screening, this algorithm resulted in a 200% lift in the detection of AAAs when compared with standard screening guidelines. Using machine learning, we also identified several new factors associated with the presence of AAAs. This automated process has been integrated into our current workflows to improve screening rates and yield of high-risk individuals for AAAs. Midterm outcomes of side branch embolization and endovascular abdominal aortic aneurysm repair. Objective. To analyze the effects of total side branch embolization and endovascular aneurysm repair, EVAR, for abdominal aortic aneurysms on the incidences of persistent type 2 endoleak, PT2L, changes in sac diameter, and reintervention. Methods. Between 2013 and 2021, all patients who underwent primary EVAR with a few exceptions were included. Side branch embolization was considered during EVAR for inferior mesenteric artery, IMA, or IMA plus lumbar artery, LA, when feasible for contrast agent use. Outcomes measured were PT2L, sac diameters, reintervention, ruptures, and aneurysm-related mortality. Radiation exposure and safety outcomes were also reported. Results. Among 732 patients who underwent EVAR, 616, 84.2%, were included. Of the 616 patients, 223, 36.2%, did not undergo side branch embolization, no E, whereas 228, 37.0%, underwent IMA only, IMA-E, and 165, 26.8%, underwent I.M.A plus LA including median sacral artery, I.M.A plus LAE. The technical success rate of I.M.A and LA embolization was 97.0% and 74.7%, respectively. Crude incidences of PT2L were significantly different from 6 months through 3 years, No-E, 27.8%, I.M.A.E, 31.7%, I.M.A plus LAE, 9.4% at 3 years, p equals 0.007. In the multivariate analysis adjusted for background differences, the incidences of PT2L were significantly higher in the No-E, odds ratio or 3.21, 95% confidence intervals, Cs, 1.08 to 9.57, p equals 0.004 and I.M.A.E or 4.86, 95% Cs, 1.68 to 14.11, p equals 0.004, compared with the I.M.A plus LAE group. Similarly, any reintervention until 3 years was significantly frequent in the No-E or 5.26, 95% Cs, 1.76 to 15.70, p equals 0.003, and I.M.A.E group, or 4.19, 95% Cs, 1.38 to 12.67, p equals 0.01. Surgical conversion and secondary rupture were seen only in 1 patient without any aneurysm-related mortality. Percent sac shrinkage from the baseline was significantly promoted in the I.M.A plus LA group, No-E, 12.1% plus or minus 16.6%, I.M.A.E, 11.4% plus or minus 16.7%, I.M.A plus LAE, 18.0% plus or minus 18.8%, p equals 0.047. Fluoroscopy time was significantly longer in the I.M.A plus LAE group, No-E, 60.2 plus or minus 47.4 minutes, I.M.A.E, 59.3 plus or minus 39.5 minutes, I.M.A plus LAE, 75.5 plus or minus 42.8 minutes, p less than 0.0001, and so do the dose area product, No-E, 424.6 plus or minus 333.4 grays cm2, I.M.A.E, 477.7 plus or minus 342.4 grays cm2, I.M.A plus LAE, 631.8 plus or minus 449.1 grays cm2, p less than 0.0001. No embolization-related complications or radiation-related adverse events were recorded. Conclusions. Preemptive embolization of I.M.A, LAs, and median sacral artery at the time of EVAR reduced the incidences of PT2L and any reintervention and promoted sac shrinkage during the follow-up period of 3 years. Risk factors and associated outcomes of postoperative delirium after open abdominal aortic aneurysm repair. Objective. Open abdominal aortic aneurysm repair (OAR) is a major vascular procedure that incurs a large physiologic demand, increasing the risk for complications such as postoperative delirium (POD). We sought to characterize POD incidence, identify delirium risk factors, and evaluate the effect of delirium on postoperative outcomes. We hypothesized that POD following or would be associated with increased postoperative complications and resource utilization. Methods. This was a retrospective study of all OR cases from 2012 to 2020 at a single tertiary care center. POD was identified via a validated chart review method based on keywords and confusion assessment method assessments. The primary outcome was POD, and secondary outcomes included length of stay, non-home discharge, 90-day mortality, and 1-year survival. Bivariate analysis as appropriate to the data was used to assess the association of delirium with postoperative outcomes. Multivariable binary logistic regression was used to identify risk factors for POD and Cox regression for variables associated with worse 1-year survival. Results. Overall, 198 OR cases were included, and POD developed in 34%, n equals 67. Factors associated with POD included older age, 74 versus 69 years, p less than 0.01, frailty, 50% versus 28%, p less than 0.01, preoperative dementia, 100% versus 32%, p less than 0.01, symptomatic presentation, 47% versus 27%, p less than 0.01, Preoperative coronary artery disease, 44% versus 28%, p equals 0.02, end-stage renal disease, 89% versus 32%, p less than 0.01, and Charlson comorbidity index score greater than 4, 42% versus 26%, p equals 0.01. POD was associated with 90-day mortality, 19% versus 5%, p less than 0.01, non-home discharge, 61% versus 30%, p less than 0.01, longer median hospital length of stay, 14 versus 8 days, p less than 0.01, longer median intensive care unit length of stay, 6 versus 3 days, p less than 0.01, postoperative myocardial infarction, 7% versus 2%, p equals 0.045, and postoperative pneumonia, 19% versus 8%, p equals 0.01. On multivariable analysis, risk factors for POD included older age, history of end-stage renal disease, lack of epidural, frailty, and symptomatic presentation. A Cox proportional hazards model revealed that POD was associated with worse survival at 1 year, hazard ratio, 3.8, 95% confidence interval, 1.6 to 9.0, p equals 0.003. Conclusions. POD is associated with worse postoperative outcomes and increased resource utilization. Future studies should examine the role of improved screening, implementation of delirium prevention bundles, and multidisciplinary care for the most vulnerable patients undergoing OR. Next article is from Surgical Endoscopy. Medical therapy has similar hemostatic efficacy with endoscopic treatment for pub patients with adherent clot, fib ulcers background. Currently, there is no clear consensus on whether medical treatment or endoscopic treatment should be used for peptic ulcer bleeding patients with adherent clot. The aim of this study is to investigate the hemostatic effects of medical treatment, single endoscopic treatment, and combination endoscopic treatment for peptic ulcer bleeding, PUB, patients with adherent clot. Methods. We retrospectively analyzed pub patients with adherent clot who underwent endoscopic examination or treatment in our center from March 2014 to January 2023 and received intravenous administration of proton pump inhibitors. Patients were divided into medical treatment, MOUNT group, single endoscopic treatment, ST group, and combined endoscopic treatment, CT group. Subsequently, inverse probability of treatment weighting, IPTW, was performed to calculate the rebleeding rate. Results. A total of 605 eligible patients were included in this study. After IPTW, the rebleeding rate in the MOUNT group on days 3, 7, 14, and 30 were 13.3, 7.3, 14.2, 7.8, 14.5, 7.9, and 14.5, 7.9, respectively. The rebleeding rates in the ST group were 17.4, 5.1, 20.8, 6.1, 20.8, 6.1, and 20.8, 6.1, respectively. The rebleeding rates in the CT group were 0.4, 0.9, 1.7, 3.3, 2.3, 4.5, and 2.3, 4.5, respectively. Although the rebleeding rate in the medical treatment group was higher, there was no significant difference among the three groups on days 3, 7, 14, and 30, p equals 0.132, 0.442, 0.552, and 0.552. Conclusions. Medical therapy has similar hemostatic efficacy with endoscopic treatment for pub patients with adherent clot, fib ulcers. However, for patients with more risk factors and access to well-equipped endoscopy centers, endoscopic treatment may be considered. The choice of treatment approach should be based on the individual conditions of the patient, as well as other factors such as medical resources available. Effects of laparoscopic sleeve gastrectomy on thyroid hormones and relationship between metabolic parameters and long-term total weight loss. Background. Bariatric surgery has significant effects on metabolic parameters and hormone levels. However, the specific impact of laparoscopic sleeve gastrectomy, LSG, on thyroid hormones and other metabolic parameters remains unclear. This study aimed to investigate the short and long-term effects of LSG on thyroid hormone levels, HbA1c, and other metabolic parameters. Methods. A total of 619 euthyroid patients without a history of thyroid disease or thyroid hormone replacement therapy were included in the study. Patients with diabetes were excluded from the study. Preoperative, 1-year postoperative, and 5-year postoperative levels of thyroid-stimulating hormone, TSH, free triiodothyronine, FT3, free thyroxine, FT4, HbA1c, and other metabolic parameters were recorded and analyzed. Results. LSG resulted in significant weight loss and improvements in metabolic parameters. At 1 year postoperatively, there were significant reductions in BMI, HbA1c, TSH, FT3, and triglyceride levels, while FT4 levels increased. A statistically significant negative correlation was found between preoperative HbA1c level and percentage of total weight loss, %TWL, value at the 5th postoperative year. Additionally, a statistically significant negative correlation was found between the 5-year change in TSH and %TWL. Conclusion. Being the first study to predict long-term total weight loss based on preoperative HbA1c, it is significant. This finding has important implications for personalized patient management and could aid clinicians in identifying individuals who may benefit most from sleeve gastrectomy as a treatment modality. This is valuable in that it emphasizes multidisciplinary work, including the endocrinologist and dietitian. Nomogram for predicting electrocoagulation syndrome after endoscopic submucosal dissection of esophageal tumors. Background. Endoscopic submucosal dissection, ESD, was widely used for the removal of esophageal tumors, and post-endoscopic submucosal dissection electrocoagulation syndrome, PEAKS, was one of the postoperative adverse events. The aim of this research was to develop and validate a model to predict electrocoagulation syndrome after endoscopic submucosal dissection of esophageal tumors. Materials and methods. Patients who underwent esophageal ESD in our hospital were retrospectively included. A predictive nomogram was established based on the results of multivariate logistic regression analysis, and bootstrapping resampling was used for internal validation. Besides, the clinical usefulness of the nomogram was evaluated using decision curve analysis, DCA, and clinical impact curve. Results. A total of 552 patients who underwent esophageal ESD were included in the study, and the incidence of PECs was 12.5%, 69,552. Risk factors associated with PEAKS, P less than 0.1, were analyzed by multivariate logistic regression analysis, and the final model included 4 variables, namely gender, diabetes, tumor size, and operation time. The predictive nomogram was constructed based on the above 4 variables, and the area under the ROC curve, AUC, was 0.811, 95% C 0.767 to 0.855. The calibration curve of the nomogram presented good agreement between the predicted and actual probabilities. DCA showed that the model improved patient outcomes by helping to assess the risk of PEAKS in patients compared to an all or no treatment strategy. In addition, the clinical impact curve of the model also indicates that the nomogram has a high clinical net benefit. Conclusion. In conclusion, we have developed a predictive nomogram for PEAKS after ESD for esophageal tumors with good predictive accuracy and discrimination. This predictive nomogram can be effectively used to identify high-risk patients with PEAKS, which will help clinicians in clinical decision-making and early intervention. Next article is from Annals of Surgical Oncology. Adjuvant therapy after upfront resection of resectable pancreatic cancer, patterns of emission and use, a prospective real-life study. Background. Little is known about adjuvant therapy, emission and use outside of randomized trials. We aim to assess the patterns of admission and use in a cohort of upfront resected pancreatic cancer patients in a real-life scenario. Methods. From January 2019 to July 2022, 317 patients with resected pancreatic cancer and operated upfront were prospectively enrolled in this prospective observational trial according to the previously calculated sample size. The association between perioperative variables and the risk of admission and at delay was analyzed using multivariable logistic regression. Results. 80 patients, 25.2%, did not receive A.I.O. The main reasons for admission were postoperative complications, 38.8%, oncologist's choice, 21.2%, baseline comorbidities, 20%, patient's choice, 10%, and early recurrence, 10%. At the multivariable analysis, the odds of not receiving it increased significantly for older patients, odds ratio, or 1.1, p less than 0.001, those having an American Society of Anesthesiologists score greater than or equal to 2 or 2.03, p equals 0.015, or developing postoperative pancreatic fistula or 2.5, p equals 0.019. The likelihood of not receiving FOLFIRINOX as it increased for older patients, or 1.1, p less than 0.001, in the presence of early stage disease, stage I-A versus IIB-3, or 2.82, p equals 0.031, and 0 versus n plus, OR3 equals 0.03, and for patients who experienced postoperative major complications, or 4.7, p equals 0.009. A twofold increased likelihood of delay in it was found in patients experiencing postoperative complications, or 3.86, p equals 0.011. Conclusions. A.I.O. is not delivered in about 1/4 of upfront resected pancreatic cancer patients. Age, comorbidities, and postoperative complications are the main drivers of admission and FOLFIRINOX non-use. Using a CA19-9 tumor marker gene test to assess outcome after pancreatic cancer surgery. Background. Cancer antigen 19-9, CA19-9, is widely used as a marker of pancreatic cancer tumor burden in response to therapy. Synthesis of CA19-9 and its circulating levels are determined by variants encoding the fucosyltransferases, FUT2 and FUT3. Individuals can be grouped into one of 4 functional FUT groups: FUT3 null, FUT low, FUT intermediate, FUT high, each with its own CA19-9 reference range based on its predicted capacity to produce CA19-9. The authors hypothesized that a FUT variant-based CA19-9 tumor marker gene test could improve the prognostic performance of CA19-9. Methods. Preoperative and pretreatment CA19-9 levels were measured, and FUT variants were determined in 449 patients who underwent surgery for pancreatic ductal adenocarcinoma, PDAC, at Johns Hopkins Hospital between 2010 and 2020, including 270 patients who underwent neoadjuvant therapy. Factors associated with recurrence-free and overall survival were determined in Cox proportional hazards models. Results. Higher preoperative CA19-9 levels were associated with recurrence and mortality for patients in the higher FUT groups, FUT intermediate, FUT high for mortality, with adjustment for other prognostic factors, hazard ratio, HR, 1.34 and 1.58, respectively, p less than 0.001, but not for those in the lower FUT groups, FUT3 null, FUT low. As a tumor marker, CA19-9 levels of 100 U/ml or lower after neoadjuvant therapy and normalization of CA19-9 based on FUT group were more sensitive but less specific predictors of evidence for a major pathologic response to therapy, little/no residual tumor, and of early recurrence, within 6 months. Conclusion. Among patients undergoing pancreatic cancer resection, a CA19-9 tumor marker gene test modestly improved the prognostic performance of CA19-9. Predictive value of a new muscle parameter in patients with resectable gastric cancer, a pooled analysis of 3 prospective trials. Background. Sarcopenia is closely associated with gastric cancer, GC, prognosis. However, its exact definition remains controversial. Methods. This study included computed tomography images and clinical data of patients from 3 prospective studies. The skeletal muscle index, SMI, and skeletal muscle radiation attenuation, SMRA, were analyzed, and a new muscle parameter, skeletal muscle gauge, SMG, was obtained by multiplying the 2 parameters. The values of the 3 indices for predicting the prognosis of patients with GC were compared. Results. The study included 717 patients. The findings showed median values of 42 square centimeters/m2 range, 36.8 to 48.2 square centimeters/m2 for SMI, 45 Hu range, 41 to 49 Hu for SMRA, and 1842 range, 1454 to 2260 for SMG. Postoperatively, 111 patients, 15.5%, experienced complications. The 3-year overall survival, OS, disease-free survival, DFS, and recurrence-free survival, RFS, were 74.3%, 68.2%, and 70%, respectively. Univariate logistic analysis showed that postoperative complications were associated with SMI, odds ratio, or 0.94, 95% confidence interval, C, 0.92 to 0.96, SMRA, or 0.87, 95% C, 0.84 to 0.90, and SMG, or 0.99, 95% C, 0.98 to 0.99. After a two-step multivariate analysis, only SMG, or 0.98, 95% C, 0.97 to 0.99, was an independent protective factor of postoperative complications. Multivariate analysis showed that SMG also was an independent protective factor of OS, DFS, and RFS. The patients were divided into low SMG, LSMG, group and high SMG, HSMG, groups. Chemotherapy benefit analysis of the patients with stage 2 low SMG showed that the OS, DFS, and RFS of the chemotherapy group were significantly better than those of the non-chemotherapy group, p less than 0.05. Conclusion. The prospective large sample data showed that the new muscle parameter, SMG, can effectively predict the short-term outcome and long-term prognosis of patients with resectable gastric cancer. As a new muscle parameter index, SMG is worthy of further study. Laparoscopic anatomic bisegmentectomy, S5 and S6, using Takasaki's approach and indocyanine green fluorescence navigation. Background. To date, most laparoscopic anatomic bisegmentectomy practices have been performed vertically, such as the resection of segments 6 and 7, segments 5 and 8, and segments 2 and 3 (1, 2, 3). However, transversal hepatectomy may be more appropriate for certain lesions that are located in a specific area. 4, 5 Herein, we present a video of a pure laparoscopic anatomic bisegmentectomy, S5 and S6, using Takasaki's approach and indocyanine green fluorescence navigation. Method. A 58-year-old male with hepatitis B virus, HBV-related hepatocellular carcinoma, HCC, was admitted to our institution. The preoperative abdominal computed tomography, CT, scan showed a 5 × 4 cm tumor located between segments 5 and 6. Right hepatectomy was not adopted because of severe cirrhosis and portal hypertension. Therefore, laparoscopic anatomic bisegmentectomy, 5 and 6, was planned. After cholecystectomy, G5 and G6 were dissected and ligated using Takasaki's Glisonian pedicle approach. 6 The ischemic line then appeared on the liver surface. An intraoperative ultrasound was used to confirm that the tumor was within the ischemic line. Afterwards, intraoperative fluorescence navigation, negative stained, was performed to detect the demarcation line and guide the transection of liver parenchymal. Results. The operative time was 225 minutes and the estimated blood loss was 150 milliliters. The total Pringle time was 75 minutes. The postoperative course was uneventful and the patient was discharged on postoperative day 8. Pathology confirmed the diagnosis of HCC and the surgical margin was negative. Conclusions. Laparoscopic anatomic bisegmentectomy, S5 and S6, is technically feasible and safe, which may be a beneficial alternative to formal right hepatectomy in some cases. Next article is from Journal of the American College of Surgeons. Operating room supply cost and value of care after implementing a sustainable quality intervention. Background. Variability in operating room supply cost is a modifiable cause of suboptimal resource use and low value of care, outcomes versus cost. This study describes implementation of a quality improvement intervention to decrease operating room supply costs. Study design. An automated electronic health record data pipeline harmonized operating room supply cost data with patient and case characteristics and outcomes. For inpatient procedures, predicted mortality and length of stay were used to calculate observed to expected ratios and value of care using validated equations. For commonly performed, one or more per week, procedures, the pipeline generated figures illustrating individual surgeon performance versus peers, costs for each surgeon performing each case type, and control charts identifying out-of-control cases and surgeons with more than 90th percentile costs, which were shared with surgeons and division chiefs alongside guidance for modifying case-specific supply instructions to operating room nurses and technicians. Results: pre-intervention control, 1,064 cases for 7 months, and post-intervention, 307 cases for 2 months. Cohorts had similar baseline characteristics across all 16 commonly performed procedures. Median costs per case were lower in the intervention cohort, $811, $525 to $1,367, versus controls, $1,080, $603 to $1,574, p less than 0.001, as was the incidence of out-of-control cases, 19, 6.2%, versus 110, 10.3%, p equals 0.03. Duration of surgery, length of stay, discharge disposition, and 30-day mortality and readmission rates were similar between cohorts. Value of care was higher in the intervention cohort, 1.1, 0.1 to 1.5, versus 1.0, 0.2 to 1.4, p equals 0.04. Pipeline runtime was 1607. Conclusions: an automated, sustainable quality improvement intervention was associated with decreased operating room supply costs and increased value of care. Home is not always where the sleep is. Effective home call on sleep, burnout, and surgeon well-being. Background: in-house calls contribute to loss of sleep and surgeon burnout. Although acknowledged to have an opportunity cost, home call is often considered less onerous, with minimal effects on sleep and burnout. We hypothesized home call would result in impaired sleep and increased burnout in acute care surgeons. Study design: data from 224 acute care surgeons were collected for 6 months. Participants wore a physiological tracking device and responded to daily surveys. The Moslick Burnout Inventory was administered at the beginning and end of the study. Within participant analyses were conducted to compare sleep, feelings of restedness, and burnout as a function of home call. Results: 171 surgeons took 3,313 home calls, 52.5% were associated with getting called, and 38.5% resulted in a return to the hospital. Home call without calls was associated with 3 minutes of sleep loss, p less than 0.01. Home call with one or more call resulted in a further 14 minutes of sleep loss, p less than 0.0001, and home call with a return to the hospital led to an additional 70 minutes of sleep loss, p less than 0.0001. All variations of home call resulted in decreased feelings of restedness, p less than 0.0001, and increased feelings of daily burnout, p less than 0.0001, figure 1. Conclusions: home call is deleterious to sleep and burnout. Even home call without calls or returns to the hospital is associated with burnout. Internal assessments locally should incorporate frequency of calls and returns to the hospital when creating call schedules. Repeated nights of home call can result in cumulative sleep debt, with adverse effects on health and well-being. Progressive reduction in preventable mortality in a state trauma system using continuous preventable mortality review to drive provider education. Results of analyzing 1,979 trauma deaths from 2015 to 2022. Background: the state legislature codified and funded the Arkansas Trauma System, ATS, in 2009. Quarterly preventable mortality reviews, PMRs, by the ATS began in 2015 and were used to guide statewide targeted education to reduce preventable or potentially preventable P/PP deaths. We present the results of this PMR education initiative from 2015 to 2022. Study design: The ATS uses a statistical sampling model of the Arkansas Trauma Registry to select 40% of the deaths for quarterly review, reflecting the Arkansas Trauma Registry mortality population. A multi-specialty PMR committee reviews the medical records from pre-hospital care to death, and hospital and regional advisory council reviews for each death. The PMR committee assigns opportunities for improvement, AUFIs, causes of death, and the likelihood of preventability for each case. Education to improve trauma care includes annual statewide trauma meetings, novel classes targeted at Level 3/4 trauma center hospital providers, trauma evidence-based guidelines, and PMR pearls. Results. We reviewed 1,979 deaths with 211 (10.6%) deaths judged to be P/PP deaths. There was a progressive decrease in P/PP deaths and AUFIs for P/PP deaths. 5 AUFI types targeted by education accounted for 72% of the 24 possible AUFI types in the P/PP cases, and 94% of the contributory AUFIs. Reductions in delay in treatment resulted in the most rapid decrease in P/PP deaths. Conclusions. Using ongoing PMR studies to target provider education led to a reduction in P/PP deaths, and AUFIs for P/PP deaths. Focusing on education designed to improve preventable mortality can result in a substantial decrease in P/PP deaths by 43%, 14% to 8%, for trauma systems. Variation in lymph node assessment for colon cancer at the tumor, surgeon, and hospital level. Background. We hypothesized that tumor and hospital level factors, compared with surgeon characteristics, are associated with the majority of variation in the 12 or more lymph nodes, LNs, examined quality standard for resected colon cancer. Study design. A dataset containing an anonymized surgeon identifier was obtained from the National Cancer Database for stage I to III colon cancers from 2010 to 2017. Multi-level logistic regression models were built to assign a proportion of variance in achievement of the 12 LN standard among the following: 1. Tumor factors, demographic and pathologic characteristics; 2. Surgeon factors, volume, approach, and margin status; and 3. Facility factors, volume and facility type. Results. There were 283,192 unique patient records with 15,358 unique surgeons across 1,258 facilities in our cohort. Achievement of the 12 LN standard was high, 90.3%. Achievement of the 12 LN standard by surgeon volume was 88.1% and 90.7% in the lowest and highest quartiles, and 86.8% and 91.6% at the facility level for high and low annual volume quartiles, respectively. In multivariate analysis, the following tumor factors were associated with meeting the 12 LN standard: age, sex, primary tumor site, tumor grade, T-stage, and comorbidities, all p less than 0.001. Tumor factors were responsible for 71% of the variation in 12 LN's yield, whereas surgeon and facility characteristics contributed 17% and 12%, respectively. Conclusions. 29% of the variation in the 12 LN standard is linked to modifiable factors. The majority of variation in this quality metric is associated with non-modifiable tumor level factors. Collaborative approach toward transplant candidacy for obese patients with end-stage renal disease. Background. An elevated BMI is a major cause of transplant preclusion for patients with end-stage renal disease, ESRD. This phenomenon exacerbates existing socioeconomic and racial disparities and increases the economic burden of maintaining patients on dialysis. Metabolic bariatric surgery, MBS, in such patients is not widely available. Our center created a collaborative program to undergo weight loss surgery before obtaining a kidney transplant. Study design. We studied the outcomes of these patients after MBS and transplant surgery. 183 patients with ESRD were referred to the bariatric team by the transplant team between January 2019 and June 2023. Of these, 36 patients underwent MBS, 20 underwent Roux-en-Y gastric bypass, and 16 underwent sleeve gastrectomy, and 10 underwent subsequent transplantation, with another 15 currently waitlisted. Both surgical teams shared resources, including dietitians, social workers, and a common database, for easy transition between teams. Results: the mean starting BMI for all referrals was 46.4 kg/m2 and was 33.9 kg/m2 at the time of transplant. The average number of hypertension medications decreased from 2, range 2 to 4, pre-surgery to 1, range 1 to 3, post-surgery. Similarly, hemoglobin A1c levels improved, with preoperative averages at 6.2, range 5.4 to 7.6, and postoperative levels at 5.2, range 4.6 to 5.8. All transplants are currently functioning, with a median creatinine of 1.5, 1.2 to 1.6 mg/dl, glomerular filtration rate 46, 36.3 to 71. Conclusions: a collaborative approach between bariatric and transplant surgery teams offers a pathway toward transplant for obese ESRD patients and potentially alleviates existing healthcare disparities. ESRD patients who undergo MBS have unique complications to be aware of. The improvement in comorbidities may lead to superior post-transplant outcomes. Impact of neoadjuvant therapy for pancreatic cancer, transatlantic trend and postoperative outcomes analysis. Background: the introduction of modern chemotherapy a decade ago has led to increased use of neoadjuvant therapy, NAT, in patients with pancreatic ductal adenocarcinoma, PDAC. A recent North American study demonstrated increased use of NAT and improved operative outcomes in patients with PAC. The aims of this study were to compare the use of NAT and short-term outcomes in patients with PAC undergoing Pancreatoduodenectomy, PD, among registries from the US and Canada, Germany, the Netherlands, and Sweden. Study design: databases from 2 multicenter, voluntary, and 2 nationwide, mandatory, registries were queried from 2018 to 2020. Patients undergoing PD for PAC were compared based on the use of upfront surgery versus NAT. Adoption of NAT was measured in each country over time. 30-day outcomes, including the composite measure, ideal outcomes, were compared by multivariable analyses. Sensitivity analyses of patients undergoing vascular resection were performed. Results: overall, 11,402 patients underwent PD for PAC, with 33.7% of patients receiving NAT. The use of NAT increased steadily from 28.3% in 2018 to 38.5% in 2020, p less than 0.0001. However, use of NAT varied widely by country: the US, 46.8%, the Netherlands, 44.9%, Sweden, 11.0%, and Germany, 7.8%. On multivariable analysis, NAT was significantly, p less than 0.01, associated with reduced rates of serious morbidity, clinically relevant pancreatic fistulae, reoperations, and increased ideal outcomes. These associations remained on sensitivity analysis of patients undergoing vascular resection. Conclusions: NAT before PD for pancreatic cancer varied widely among 4 Western audits, yet increased by 26% during 3 years. NAT was associated with improved short-term outcomes. Adherence rate to Alliance for Clinical Trials in Oncology Z0011 trial based on breast cancer subtype. Background: the American College of Surgeons Oncology Group Z0011, ACOSOG Z0011 or Z11, trial demonstrated no survival advantage with completion axillary lymph node dissection, ALND, for patients with T1-2 breast cancer, 1 to 2 positive SLNs who received adjuvant chemoradiation therapy. More than 70% of the cohort had estrogen receptor, ER+ tumors. There is paucity of data on the adherence rate to Z11, as well as a dearth of data on the applicability of Z11 for the different subtypes. We conducted a large hospital-based study to evaluate the adherence rate to Z11 based on subtypes. Study design: the National Cancer Database was queried to evaluate 33,859 patients diagnosed with T1-2, N1, and M0 breast cancer treated with lumpectomy with negative margins, and adjuvant chemoradiation therapy between 2012 and 2018. Patients were classified into 3 groups: 1. ER plus/HER2 minus, 2. ER minus/HER2 minus, and 3. HER2 plus regardless of ER status. The revised scope of the Regional Lymph Node Surgery 2012 was used to classify patients into those who underwent an SLN or ALND. Differences in use of ALND by subtypes were compared. The Kaplan-Meier method and log-rank test were used to compare overall survival, OS. A p-value of less than 0.05 was considered statistically significant. Results. For ER plus/human epidermal growth factor receptor 2, HER2 minus, ER minus/HER2 minus, and HER2 plus tumors, the rate of ALND was 43.6%, 50.2%, and 47.8%, respectively. The 5-year OS for SLN and ALND for the entire cohort was 94.0% and 93.1%, p equals 0.0004. For ER plus/HER2 minus, it was 95.4% and 94.7%, p equals 0.04. For ER minus/HER2 minus, it was 84.1% and 84.3%, p equals 0.41. For HER2 plus, it was 94.2% and 93.2%, p equals 0.20. Multivariable Cox proportional hazard regression analysis demonstrated no significant survival differences between SLN and ALND, p equals 0.776. Conclusions. Z11 is applicable for women with early N1 disease, regardless of subtypes. ALND did not confer a survival advantage over SLN. Despite this, up to 50% of patients who fit Z11 criteria continue to undergo ALND. Increasing injury intensity among 6,500 violent deaths in the state of Maryland. Background. Anecdotal evidence strongly suggests there has been a rise in violent crimes. This study sought to examine trends in injury characteristics of homicide victims in Maryland. We hypothesized that there would be an increase in the severity of wound characteristics. Study design. The Office of the Chief Medical Examiner is a statewide agency designated by law to investigate all homicides, suicides, or unusual or suspicious circumstances. Using individual autopsy reports, we collected data among all homicides from 2005 to 2017, categorizing them into 3 time periods: 2005 to 2008, early, 2009 to 2013, mid, and 2014 to 2017, late. Primary outcomes included the number of gunshots, stabs, and fractures from assaults. High violence intensity outcomes included victims having 10 or more gunshots, 5 or more stabs, or 5 or more fractures from assaults. Results. Of 6,500 homicides, annual range 403 to 589, the majority were from firearms, 75%, followed by stabbings, 14%, and blunt assaults, 10%. Most homicide victims died in the hospital, 60%. The average number of gunshots per victim was 3.9, range 1 to 54, stabs per victim was 9.4, range 1 to 563, and fractures from assaults per victim was 3.7, range 0 to 31. The proportion of firearm victims with at least 10 gunshots nearly doubled from 5.7% in the early period to 10%, p less than 0.01, in the late period. Similarly, the proportion with 5 or more stabbings increased from 39% to 50%, p equals 0.02, and assault homicides with 5 or more fractures increased from 24% to 38%, p less than 0.01. Conclusions. In Maryland, the intensity of violence increased across all major mechanisms of homicide. Further follow-up studies are needed to elucidate the root causes underlying this escalating trend. Coronary artery calcification and risk of cardiac complication in geriatric trauma population. Background. Better means of identifying patients with increased cardiac complication, CC, risk is needed. Coronary artery calcification, CAC, is reported on routine chest CT scans. We assess the correlation of CAC and CCs in the geriatric trauma population. Study design. A prospective, Observational study of patients 55 years and older who had chest CT scan from May to September 2022 at a Level 1 trauma center. Radiologists scored CAC as none, mild, moderate, or severe. None to mild CAC, NM-CAC, and moderate to severe CAC, MS-CAC, were grouped and in-hospital CCs assessed: arrhythmia, ST elevation, myocardial infarction, STEMI, non-STEMI, congestive heart failure, pulmonary edema, cardiac arrest, cardiogenic shock, and cardiac mortality. Univariate and bivariate analyses were performed. Results: 569 patients had a chest CT, of them 12 were excluded due to missing CAC severity. Of 557 patients, 442, 79.3%, had none to mild CAC and 115, 20.7%, has MS-CAC. The MS-CAC group was older, 73.3 versus 67.4 years, with fewer male patients, 48.7% versus 54.5%, had higher cardiac-related comorbidities, and had higher abbreviated injury scale chest injury scores. The MS-CAC group had an increased rate of CC, odds ratio, or 1.81, p equals 0.016. Cardiac complications statistically more common in MS-CAC were congestive heart failure, or 3.41, p equals 0.003, cardiogenic shock, or 3.3, p equals 0.006, non-STEMI 1 or 2, or 2.8, p equals 0.017, STEMI, or 5.9, p equals 0.029, and cardiac-caused mortality, or 5.27, p equals 0.036. No statistical significance between pulmonary edema, p equals 0.6, new onset arrhythmia, p equals 0.74, or cardiac arrest, p equals 0.193. Conclusions: CAC as reported on chest CT scans demonstrates a significant correlation with CC and should warrant additional cardiac monitoring. Next article is from Journal of Trauma and Acute Care Surgery. Goals of care are rarely discussed prior to potentially futile trauma transfer. Is it okay to say no? Background: it is unknown how often the physician-to-physician trauma transfer conversation includes a discussion of patient goals of care, GOC. We hypothesize that physicians would rarely discuss GOC on transfer calls when faced with patients with catastrophic injuries. Methods: we completed a retrospective case series of trauma patients transferred to an ACS-verified Level I trauma center between 2018 and 2022 who died or were discharged to hospice without surgical intervention within 48 hours. Transfer call recordings were analyzed for GOC conversations. Results: a total of 5,562 patients were accepted as transfers and 82, 1.5%, met inclusion criteria. 80 of the 82 patients had recorded transfer calls and were analyzed. The most common transfer reason was traumatic brain injury, TBI, and need for neurosurgical capabilities, 53%, followed by complex multisystem trauma, 23%. There was explicit discussion of code status prior to transfer in 20% and a more in-depth GOC conversation for 10% of patients. Appropriateness of transfer was discussed in 21%, and at least one physician expressed explicit concerns of futility for 14%, though all were subsequently transferred. Code status was changed immediately upon arrival for 15% for patients, and 19% of patients transferred for neurosurgical expertise were deemed to have non-survivable injuries based on imaging and examination that were unchanged from the referring hospital. Conclusion: among a group of profoundly injured trauma patients at high risk of death, an explicit discussion of GOC occurred in just 10%. This suggests that even when the catastrophic nature of patient injury is understood, transfers still occur, and patients and their families are subjected to an expensive, disruptive, and displacing experience with little to no anticipated benefit. A discussion of GOC and therapeutic objectives should be considered in all severely injured trauma patients prior to transfer. Predicting high-intensity resuscitation needs in injured patients in the post-hemostasis phase of care following intervention. Background: best resuscitation practices in the post-hemostasis phase of care are poorly defined, This phase of care is characterized by a range of physiologic derangements and multiple therapeutic modalities used to address them. Using a cohort of injured patients who required an immediate intervention in the operating room or angiography suite following arrival to the emergency department, we sought to define high-intensity resuscitation, HIR, in this post-hemostasis phase of care. We hypothesized that those who would require her could be identified, using only data available at intensive care unit, ICU, admission. Methods. Clinical data were extracted for consecutive injured patients, 2016 to 2019, admitted to the ICU following an immediate procedure in the operating room or angiography suite. High-intensity resuscitation thresholds were defined as the top decile of blood product, greater than or equal to 3 units, and/or crystalloid, greater than or equal to 4L, used in the initial 12 hours of ICU care and/or vasoactive medication used between ICU hours 2 and 12. The primary outcome, HER, was a composite of any of these modalities. Predictive modeling of HER was performed using logistic regression with predictor variables selected using least absolute shrinkage and selection operator, LASSO, estimation. Model was trained using 70% of the cohort and tested on the remaining 30%. Model predictive ability was evaluated using area under receiver operator curves. Results. 605 patients were included. Patients were 79% male, young, median age, 39 years, severely injured, median injury severity score, 26, and an approximately 3:2 ratio of blunt to penetrating mechanisms of injury. A total of 215, 36%, required HER. Predictors selected by LASSO included shock index, lactate, base deficit, hematocrit, and INR. The area under receiver operator curve for the LASSO-derived HER prediction model was 0.82. Conclusion. Intensive care unit admission data can identify subsequent HER in the post-hemostasis phase of care. Use of this model may facilitate triage, nursing ratio determination, and resource allocation. A pilot clinical trial of the screening and tool for awareness and relief of trauma for survivors of gun violence. Background. Survivors of gun violence have significant sequelae including re-injury with a firearm and mental health disorders that often go undiagnosed and untreated. The Screening and Tool for Awareness and Relief of Trauma, START, is a targeted behavioral mental health intervention developed for patients who come from communities of color with sustained and persistent trauma. Methods. In this pilot study, we evaluate the feasibility of completing a randomized controlled trial to test the START intervention. Using a mixed method study design, we used both quantitative and qualitative data collection to assess the START intervention and the feasibility of completing a randomized controlled trial. The purpose of this study was to estimate important study parameters that would enable a future randomized controlled trial. Results. We were able to make conclusions about several crucial domains of a behavioral intervention trial. 1. Recruitment and retention. We had a high follow-up rate, but our recruitment was low, 34% of eligible participants. 2. Acceptability of the intervention. The addition of audiovisual resources would make the tools more accessible. 3. Feasibility of the control, more appropriate for a stepped wedge cluster randomized controlled trial design. 4. Intervention fidelity. There was an 81% concordance rate between the fidelity survey results and the audio recordings. 5. Approximate effect size. There was a 0.4 point decrease in the PTSD checklist, civilian version in the control compared with a 10.7 point decrease in the treatment group for the first month. Conclusion. While it was feasible to conduct a randomized controlled trial, our findings suggest that a stepped wedge cluster randomized controlled trial design may be the most successful trial design for the START intervention. In addition, the inclusion of a credible messenger to recruit participants into the study and the development of audiovisual resources for START would improve recruitment and effectiveness. Safety and feasibility of targeted mesenteric approaches with cono-S anastomosis and extended mesenteric excision in ileocolic resection and anastomosis in Crohn's disease. Background. The mesentery has recently been implicated in the pathophysiology of Crohn's disease, CD, and several techniques have been developed to target the mesentery to reduce its influence on recurrence. We aim to describe short-term safety and feasibility after these approaches. Methods. This is a comparative, retrospective, single-center cohort study of consecutive CD patients undergoing primary or redo ileocolic resection from 2015 to 2022 with Cono-S anastomosis, KSA, extended mesenteric excision, EME, only, or both, mesenteric excision and exclusion, ME. Results: 186 patients underwent KSA, N equals 74, M, N equals 66, or ME, N equals 46. The groups had comparable baseline characteristics. The ME group operative time was longer, median, 187 versus KSA 170, M 152 min, P less than 0.01. Postoperatively, the groups had similar lengths of stay, median 4 days, readmissions, 9.1%, major postoperative complications, 6.5%, and anastomotic leaks, 1.1%. Conclusion: targeting the mesentery with novel surgical approaches for ileocolic Crohn's disease was safe and feasible for short-term follow-up. Association between COVID-19 diagnosis and postoperative outcomes in sleeve gastrectomy and Roux-en-Y gastric bypass, a national cohort study. Background: we seek to determine the association between COVID-19 diagnosis and postoperative outcomes following bariatric surgery. Methods: using the Metabolic and Bariatric Surgery Accreditation Quality Improvement Project (MSAQUP) database, patients undergoing sleeve gastrectomy and gastric bypass without a COVID-19 diagnosis were 2-to-1 propensity score matched to those with COVID-19 infection pre or postoperatively. Results: 1,369, 0.74%, and 1,331, 0.72%, patients had a COVID-19 diagnosis within 14 days prior to or 30 days after their operation, respectively. Patients with preoperative COVID-19 infection had equivalent outcomes to COVID-19 negative patients, all P greater than 0.05. Postoperative COVID-19 diagnosis was associated with worse outcomes, including increased risk of anastomotic/staple line leak, 1.1% versus 0.1%, P less than 0.001, postoperative pneumonia, 2.9% versus 0.1%, P less than 0.001, and 30-day reoperation, 2.1% versus 0.9%, P equals 0.002. Conclusions: postoperative diagnosis of COVID-19 after bariatric surgery is associated with worse outcomes. However, it is safe to perform these procedures on patients recently convalesced from COVID-19 infection. Factors associated with stoma closure after cytoreductive surgery. Background: the rate of stoma closure after cytoreductive surgery, CRS, plus or minus hypothermic intraperitoneal chemotherapy, HIPEC, is reportedly low. This study aimed to assess predictors of stoma reversal. Methods: we retrospectively analyzed all patients who underwent CRS with temporary ostomy at our center between 2009 and 2021, and compared reversed versus non-reversed patients. Results: out of 625 CRS, 72, 11.5% patients were included, median age 62 years, 65% female, 75% with HIPEC, 53, 74% achieved stoma closure. Reversed patients had less high-grade tumors, more appendiceal mucinous neoplasms, less ovarian primaries, and more loop ileostomies. The most common reason for non-reversal was disease progression or death, 14 cases, 74%. At multivariate analysis, low/intermediate grade tumor differentiation was associated with higher stoma closure rate. Conclusion: in our study, 74% of patients achieved stoma closure after CRS with temporary ostomy. The strongest predictor of stoma closure was a low/intermediate grade tumor. Peer-reviewed journal publication rates of award-winning presentations from a multidisciplinary multi-institutional medical education consortium annual research forum, 40-year experience. Introduction. Resident research has been mandated by the Accreditation Council of Graduate Medical Education across all specialties. Southeast Michigan Center for Medical Education, SMCM, has an annual research forum for resident competition, and we assess the publication status of award-winning presentations. Methods. The SEMCM Research Forum's winning presentations from 1978 to 2018 were reviewed. The author's information and keywords from the abstract's title were used to search PubMed at Google Scholar databases for publications. Descriptive statistics were generally used to characterize the data. Results. Of 147 winning projects, 62%, 78,126, were oral and 48%, 1021, were poster presentations, 88, 60%, were published. Obstetrics and gynecology had the highest publication rate, 71%, followed by surgical, 61%, and medical specialties, 48%. Conclusion. While 60% of the award-winning presentations at the SEMCM Research Forum were published, more work needs to be done to examine the barriers preventing the publication of the remaining projects. Next article is from World Journal of Surgery. April 2024, Volume 48, Issue 4. Enhanced Recovery After Surgery Recommendations That Most Impact Patient Care, a Multi-Institutional, Multidiscipline Analysis in the United States. Background. Compliance to the entire Enhanced Recovery After Surgery, ERAS, protocol improves surgical recovery, where higher compliance improves outcomes. However, specific items may predict improved recovery more than others. Studies have evaluated the impact of individual ERAS recommendations, though they are either single-center, not based in the United States, US, or focus on colorectal procedures only. This study aims to evaluate compliance on surgical outcomes in two large healthcare systems in the U.S. across 4 surgery types. Methods. Compliance to individual recommendations, limited patient characteristics, and outcomes data from 2 U.S. ERAS Centers of Excellence, CO, for hepatectomy, pancreatectomy, radical cystectomy, and head and neck, HN, resections were evaluated. Outcomes included 30-day Clavin-Dindo greater than or equal to 3, readmission, mortality, and length of stay, LOS. Multivariate regressions were performed as appropriate for the data for each surgery type. Clavin greater than or equal to 3 was included to control for severity of complications, and the co-variable was force retained. Results. A total of 2,886 records were analyzed. Controlling for co and severity of patient complications, early removal of Foley catheter was associated with significant reductions in loss in the liver, pancreas, and HN procedures and reductions in complications in the liver and pancreas. Limited use of NG tubes reduced loss in the pancreas and complications in urology. Oral carbohydrate loading reduced loss in the pancreas, and patient education reduced mortality in HN patients. Conclusions. This study reports the effect of ERAS compliance on outcomes, by surgery type, in a multi-institutional U.S. setting. Future studies should validate these findings and consider surgery-specific predictive models comprised of individual ERAS recommendations in real-world applications. A cross-sectional survey on surgeon retention in the COSEXA region after specialist training. Have things changed? Background. Increasing surgical specialist workforce density in sub-Saharan Africa is essential for improving access to surgical care. However, outmigration creates a significant challenge to attaining provider targets. We aim to determine the rates and trends of retention of surgeons in the College of Surgeons of East Central and Southern Africa (COSEXA) regions. Methodology. An online, web-based survey was distributed to COSEXA surgeons who graduated from 2004 to 2020. Current practice and migration patterns were visualized using descriptive analyses and logistic regression models. Results. Response rate was 48%, 270,557. Most respondents trained as general surgeons and practiced in Ethiopia, Kenya, Zimbabwe, and Zambia. Majority practiced in public hospitals, 74%, and were active in research, 81%, teaching, 84%, and leadership, 55%. Overall country, 85%, regional, 92%, and Africa retention rates, 99%, were high with 100% country retention in Rwanda, Botswana, Lesotho, and Namibia. Tanzania had the lowest retention, 61%. Highest interregional migration occurred from East to Southern Africa, 26%, and continental outmigration occurred from Zambia, Zimbabwe, and Kenya. On bivariate analysis, outmigration from training country and region was associated working with a non-governmental organization, P equals 0.002 and 0.0003, or a specialized hospital, P equals 0.046 and 0.011. A multiple regression model with type of institution and leadership was a poor fit. McFadden 2 South African Rand equals 0.055, P equals 0.082. Conclusion. Retention rates of surgeons trained by COSEXA in the region remain remarkably high. This can be taken as an indicator of success of the training model to increase surgical workforce density. However, contributory factors need to be qualitatively explored. Effects of botulinum toxin and 2 indicators of loss of DOM. Background. In patients with large ventral hernias, botulinum toxin to external and internal oblique muscles decreases thickness and increases length. We examine the impact of botulinum toxin in the amount of loss of domain according to 2 ratios and in hernia size. Methods. Between October 2021 and November 2023, 20 patients with ventral hernias measuring 10 cm or more on the horizontal size underwent the administration of 50 units of botulinum toxin to each external and each internal oblique muscle 4 weeks before their surgery. Incisional hernia volume to peritoneal volume ratio, and hernia size were compared before and 4 weeks after the injection of botulinum toxin. Comparisons between all variables obtained before and after the administration of botulinum toxin were performed using either the paired t-test or the Wilcoxon-signed rank test. Pearson correlation coefficient was used to analyze associations between initial conditions and further changes observed after botulinum toxin injection. Results. We observed a 42% reduction in muscle amplitude, 16% increase in intra-abdominal volume, 28% decrease in herniated volume, decreases of 6% in IHV/PV ratio and of 11% in V ratio, 11% reduction of hernia width, and decrease of 10% in rectangular and elliptical hernia areas. Conclusions. In patients with large ventral hernias, botulinum toxin is associated with reduction of hernia size and decrease in loss of domain, the latter not being significant when less than 10% of the visceral block is herniated. Association between fibrosis around the tumor and postoperative infectious complication in patients with esophageal cancer who underwent preoperative therapy. Background. Multidisciplinary treatment combining chemotherapy, chemoradiation therapy, CRT, and surgery has been utilized for advanced esophageal cancer. However, preoperative treatment could cause postoperative inflammation and complications. We hypothesized that fibrosis surrounding tumor tissue caused by preoperative treatment could induce postoperative systemic inflammation and influence postoperative complications. Methods. Surgical specimens from patients with thoracic esophageal cancer who underwent preoperative CRT, 38 cases, or chemotherapy, 77 cases, and those who received no preoperative treatment, 49 cases, were evaluated to measure the fibrotic area adjacent to the tumor, 10 mm from the tumor edge, by applying ozone staining. Pleural effusion and peripheral blood serum interleukin-6 levels were analyzed to evaluate local and systemic postoperative inflammation in 37 patients. Results. The fibrotic areas around the tumors were significantly larger in patients who underwent preoperative CRT than in patients who underwent chemotherapy, p less than 0.001, or who had received no preoperative therapy, p less than 0.001. Infectious complications were higher in patients who underwent preoperative CRT than chemotherapy, p equals 0.047, or surgery alone, p less than 0.001. The patients with larger fibrotic areas had more infectious complications, p equals 0.028. Multivariate analysis showed that both a large fibrotic area and preoperative CRT were correlated with infectious complications, but not significantly. Pleural effusion interleukin-6 was significantly higher in patients who underwent preoperative CRT than in patients who received no preoperative therapy, p equals 0.013. Conclusions. A large fibrotic peritumoral esophageal tissue area after preoperative treatment could cause postoperative inflammatory response and infectious complications. Contemporary trends in colorectal cyst excision, an analysis of the Paediatric National Surgical Quality Improvement Program. Background. Colorectal cysts are rare congenital anomalies of the biliary tree that may lead to obstruction, chronic inflammation, infection, and malignancy. There is wide variation in the timing of resection, operative approach, and reconstructive techniques. Outcomes have rarely been compared on a national level. Methods. We queried the Paediatric National Surgical Quality Improvement Program, SCUP, to identify patients who underwent colorectal cyst excision from 2015 to 2020. Patients were stratified by Hepatocellular, HD, versus Roux-en-Y Hepatocellular, RNH, use of minimally invasive surgery, MIS, and age at surgery. We collected several outcomes, including length of stay, LOS, reoperation, complications, blood transfusions, and readmission rate. We compared outcomes between cohorts using nonparametric tests and multivariate regression. Results. Altogether, 407 patients met the study criteria, 150, 36.8%, underwent RNH reconstruction, 100, 24.6%, underwent MIS only, and 111, 27.3%, were less than 1 year old. Patients who underwent open surgery were younger, median age 2.31 versus 4.25 years, p equals 0.002, and more likely underwent RNH reconstruction, 42.7% versus 19%, p equals 0.001. On adjusted analysis, the outcomes of loss, reoperation, transfusion, and complications were similar between the type of reconstruction, operative approach, and age. Patients undergoing RNH had lower rates of readmission than patients undergoing HD, 4.0% versus 10.5%, or 0.34, c. 0.12, 0.79, p equals 0.02. Conclusions. In children with colorectal cysts, most short-term outcomes were similar between reconstructive techniques, operative approach, and age at resection, although HD reconstruction was associated with a higher readmission rate in this study. Clinical decision-making should be driven by long-term and biliary-specific outcomes. Thank you for listening to This Week in Surgery, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.